Hello, and thank you so much for coming. My name is Jo-Beth Stamm. I'm a registered nurse and a student at Bluefield State College. And today we're going to discuss the implementation of pediatric mock codes at Raleigh General Hospital's emergency department. Now, when I set out to do a change project in this department, I asked myself what would be the most beneficial change I could make for our nurses and of course for our patients and their families. One thing I wish I'd had throughout my nursing career so far was mock codes, and specifically pediatric mock codes. I presented this idea first to our emergency department director, as well as one of the nurses from our education department, who also used to be an emergency department staff member. And both of these nurses felt that this would be a great change that we could make in this department to help better the care of our patients. Now, along with these two nurses, we established a goal. And the goal we established was to improve the proficiency and confidence of Raleigh General Hospital emergency department staff in caring for pediatric emergency patients. To achieve this goal, we set out with two different objectives. The first objective was to conduct quarterly pediatric mock code practice scenarios on shift at Raleigh General Hospital's emergency department. Our goal for implementation of this project was April 1st of 2020. And a second objective was to implement a policy and procedure change for the continued practice of pediatric mock code practice scenarios at Raleigh General Hospital. Again, our goal for this was April 1st, 2020. Now, once we'd identified the problem and identified our plan to address this problem, we had to establish what our driving forces and restraining forces were for this project. So LifePoint Industries is the corporate umbrella organization over top of Raleigh General Hospital. LifePoint Industries recently put out a dictate to all their hospitals' education departments to implement mock codes at least every 6 months in any unit where they had not had a code in the previous 6 months. And this was separate for adult and pediatric patients if that patient sees pediatric patients. Now, in our emergency department, we attempt resuscitation for adult cardiac arrest patients on a regular basis. So that's a non-issue for us with adults. But luckily, we do sometimes go months or longer without seeing a true pediatric life or death emergency. Because these instances are very low occurrence, they're also very high risk. And so the need for continuing education is there. So that's one major driving force behind this project. In addition to that and our continuing education need, a major driving force is the goal to improve the competency and the confidence of nursing department staff when caring for pediatric emergent patients. And of course, our major goal here is to improve our patient outcomes. Now, restraining forces for this project include that this is a very busy emergency department, and it's a very high acuity emergency department. So even when they don't have that many patients, oftentimes the nurses are overloaded with the number of tasks they need to accomplish. We were very concerned about presenting to a shift to perform these emergency scenarios when nursing staff is already overwhelmed. So that was one major concern for us. The other major restraining force we considered was the time requirement for the scenario proctors. So the department, or the environment rather, in which we intend to implement this project is Raleigh General Hospital. This is a hospital in Beckley, West Virginia. It's a 300-bed facility. This is a certified stroke and chest pain center, as well as a level 3 trauma center. In the emergency department, they have 33 beds, and that's a combination of the main emergency department as well as their prompt care area. During their peak hours of noon to midnight, they staff approximately 10 nurses. That's a combination of registered nurses and licensed practical nurses. They also have roughly 2 emergency department techs and then 2 physicians as well as 2 med-level providers, either nurse practitioners or physician's assistants. Every team member in the department, if it's a nursing team member or greater, is expected to maintain a Pediatric Advanced Life Support Certification, or a PALS certification, and that recertifies every 2 years. So at the beginning of this project, we put out a needs assessment to the staff. We had 20 respondents to that survey. The first question we asked on that survey was, do you believe nursing participation in a pediatric emergency simulation would be beneficial? And the overwhelming answer was yes. The next question was, how prepared clinically do you feel to participate in a pediatric emergency scenario today? And to that question, of the 20 participants, one person said they felt very prepared, 17 felt somewhat prepared, but 2 people, even though they've had pediatric advanced life support, felt somewhat unprepared to care for a pediatric patient. These are the people that we can really help with this change project. The next question we asked was, how would you rate your stress level related to the idea of a pediatric emergency presenting to your department right now? And we asked this question about stress because when you have an increase in your stress level, especially if your stress level is very, very high, you wind up with a situation in which your thinking becomes somewhat clouded. And if your stress level is very high and your thinking is clouded while you're taking care of an emergent patient, you become that much more likely to make a mistake and cause patient harm. So the idea of stress level is very important here. So of the 20 people we asked the question about their stress level, 3 people felt their stress level would be very high, again, with that clouded thinking and that risk for patient harm. 13 people felt it would be somewhat high, and just 4 people felt that their stress level would be somewhat low. So these are people that we can help with this problem. The next question we asked was, how many pediatric emergencies have you participated in within the past 2 years? And we were trying to get an idea of how often they were practicing their skills on real patients. 2 people had taken care of 0 emergent pediatric patients, 4, 1 to 2, 4, 3 to 4 patients, and 10 people had taken care of 5 or greater pediatric emergencies in the last 2 years. Now remember, we did let our respondents decide for themselves what constituted a pediatric emergency. So for some people, it was only that true life or death situation. For others, it might have been more of a lower level situation. And the next question we asked was, do you learn best in a group setting or one-on-one? And the overwhelming majority, 16 people, felt they learned best in a group setting. And we were trying to decide if we needed to really adjust how often we do a major scenario or just one-on-one education. So after putting out this survey, we established a committee for this change project. And this committee consisted of the change agent, that is me. It consisted of our emergency department director, Lorinda Hart, Daphne Brown, a master's educated nurse in our education department. Courtney Shumate is an emergency department charge nurse and our clinical coordinator on day shift. Cynthia Clark is a master's educated nurse as well as one of our day shift staff nurses and an educator in a local nursing program. And then our final 3 nurses are all emergency department staff nurses on day shift, night shift, and mid shift respectively. So we did come up with a good sample of people who work on all shifts. We established an action plan for this, and we determined that our pediatric mock codes would occur on a quarterly basis across all shifts in the emergency department. And these mock codes would occur while nurses were working on their shifts. They would be unannounced. So we'll show up with a mannequin, and the scenario starts right then. And our goal here would be to make it during less busy times off the shift and to work with the charge nurse to make sure that we're not going to overwhelm the department. We set forth a few guidelines for this. The learning focus for these mock codes will be changing quarterly. So it won't always be the same scenario. Maybe sometimes it'll be a respiratory scenario or a shock scenario, trauma, or a full cardiac arrest. The length of these will be kept to 10 minutes or less to not, again, stress the department and take nurses away from their patients. And a structured debriefing will follow the scenarios in order to help people fully realize that educational potential. And finally, they will be interdisciplinary. We are encouraging the physicians and mid-level staff to participate, as well as radiology, phlebotomy, respiratory, so that we can all get the most out of it that we can. Now, our go-live date for this project, as I've said before, was hoping to be by April 1st, 2020. Now, the COVID-19 pandemic has affected all aspects of our lives, and it's also affected this project. While we are unable to implement this project at this time due to the COVID-19 pandemic, we do still have a hopeful projected implementation date of mid to late summer of 2020. And the definite date for that will be determined once this pandemic has resolved. So what worked well here and what did not? What worked well, the staff had great enthusiasm and great participation here. I got a lot of fantastic feedback from our nurses. They're all very excited to see this happen. And supplies. We even had emergency department staff saving expired supplies so that we could use it for our projects and have the same type of supplies in our scenarios that they would be using in real life. And that makes it just that much more realistic. So that went really, really well. And then as far as what did not go well, COVID-19. It was unexpected and no one can do anything about that. Gathering as a committee actually did prove to be pretty challenging. We had to make quite a few decisions and even committee meetings on a one-on-one basis over the telephone. So that actually was rather challenging. And finally, we did have a little bit of trouble with some equipment. Our rhythm generator did not match our code cart monitor, and so we had to kind of come up with some other ideas to make that work. Otherwise, I think overall, this has gone really well so far. Nelson Mandela said, "Education is the most powerful weapon which you can use to change the world." Our hope with this is to change the lives of our pediatric patients and their families. Again, my name is Jo-Beth Stamm. I'm a registered nurse and student at Bluefield State College, and this has been Implementation of Pediatric Mock Codes in the Emergency Department. Thank you so much.